Good afternoon, everyone. Hello from Sheffield. I just want to thank Coeliac UK for arranging this. I know this has been arranged at really short notice, but it's amazing that we can do this digitally and I'm still able to talk to you all. And I hope everyone's well and safe as I speak to you all. So today I wanted to talk a little bit about nutrition in celiac disease, and particularly looking at an issue that's become more prevalent, I think, both dietetically and from the patients that we see referred into our services. So you can see from this slide here, I have two spacemen floating in there, and it's talking about persisting symptoms, personalised diets in celiac disease, and how we approach these patients that do present with persisting symptoms, and why I think we may have a problem with how we manage these patients nutritionally and dietetically, and how maybe we could go forward into the future with these patients that present to our clinics quite often. So I did want to just start a little bit talking about polydiagnosis in celiac disease. Obviously, we know there are a range of conditions that are associated with celiac disease that we will commonly see. But also within that, there's what we would class as non-responsive celiac disease. That can be both primary and secondary. So this is usually the first 6 to 12 months of diagnosis. And patients may never respond to a gluten-free diet. As far as we can tell, a well-followed and adherent gluten-free diet, but equally they may get initially better and then they may have a relapse of symptoms. So what we see is signs and symptoms, ongoing raised celiac serology like tissue transglutaminase and endometrial antibody, maybe hematinic deficiencies like B12 and folate, or mucosal recovery, but ongoing GI symptoms or symptoms beyond the gut and maybe even cognitive effects. Now, I would separate these two I would separate non-responsive celiac disease into two groups. So I would say there's a group of people that have conditions associated with celiac disease. So they may have celiac disease and this condition, such as irritable bowel, maybe microscopic colitis, lactose intolerance, or exocrine pancreatic insufficiency. So those are conditions that may cause symptoms beyond celiac disease. But then we also have maybe people who are slow to respond to the gluten-free diet. They may just be having ongoing gluten exposure, which is the most common reason that we see for patients with non-responsive celiac disease, and we'll be coming back to that. And also a small subset of patients who may have refractory celiac disease and also a super sensitivity or an acute sensitivity to gluten, maybe beyond what we would normally aspect, maybe sensitive to just very low micrograms of gluten cross-contamination. So we have people that have ongoing celiac disease in that red set of groups of conditions, and then we have conditions associated with celiac disease. So I think it's important to differentiate before we go on. Now, if we drill down a little bit further into those patients with persisting symptoms, so we think maybe up to about 30% of patients have persisting symptoms with celiac disease on a gluten-free diet. Most people do respond to a standard gluten-free diet. They feel better, the celiac serology comes down, and if they have a repeat duodenal biopsy, we see mucosal recovery or healing. So again, just emphasizing the range of conditions that we might see here. Some patients with persisting symptoms, we can't always just associate it to non-adherence. It may be small intestinal bowel overgrowth, maybe a lactose or fructose intolerance, and like I was saying, microscopic colitis, and a small subset of these patients may have genuine refractory disease. So I think it's very important, particularly from dietetics, we understand where nutrition fits in with these patients. And what we very much would want to see is a protocol carefully delineating and a differential diagnosis with these patients. So if someone presents with non-responsive or they're still having symptoms, then we would very much want to think about what's going on. So they should really be double checked just to make sure they actually have celiac disease. We've certainly seen this in my practice that people have been referred in with non-responsive celiac disease, and it transpires the primary diagnosis was not what we thought it was. So that needs to be confirmed. And then we need to exclude these other conditions. Patients may want to have a fecal elastase, a fecal calprotectin, stool culture, other blood markers to exclude things that may be causing their symptoms. And at that point, if they're having a repeat biopsy, which I think is central to these patients, really biopsy dictates what we do, particularly dietetically. Then ideally you would have a dietetic review. Is the patient non-adhering? Are they having inadvertent or advertent gluten in their diet? Are they super sensitive or slow healing? Really, we want to be careful at where dietetics comes into the picture. My worry with some of these patients, and again, this has happened in my practice, is maybe these patients present for dietetic review and we're missing this delineation and differential diagnosis picture. And the patient may get put on, maybe it's decided they have functional symptoms, maybe it's decided they have IBS symptoms, maybe it's decided that they have a super sensitivity. And we're doing that blind. We're doing that dietetically blind without really knowing what's driving their symptoms. Yes, of course, a lot of these patients will be maybe having low levels of gluten or just not being able to follow the diet for whatever reason. And a dietitian is really important to be able to maybe exclude the need for rebiopsy if it's obvious that they're eating gluten. So we're very important, but I think we need to see where we fit into this triage and this differential diagnosis process. So I do want to come on to how we differentiate these patients into different groups. So I just wanted to touch really on celiac serology, tissue transglutamides and endomeseal antibodies. And I really want to touch about what I think is a seminal study in the area from Dr. Sylvester. It's a Canadian gastroenterologist who's done this meta-analysis of looking at celiac serology and its use in terms of detecting villus atrophy. So what we have here is patients treated, untreated with celiac disease and patients on AGFD. And what I would highlight here is in diagnosis, then celiac serology, both TTG and EMA, has a very high sensitivity and a very high specificity. But what I would draw your attention to, so, in untreated celiac disease, the serology has a very high positive predictive value and it's great for screening and diagnosis. But what I would draw your attention to here is the level of sensitivity when patients have been on a gluten-free diet. And it's much lower. And this has implications for how we use serology in these patients. So I'd like to show you this 2x2 box. I know this looks a little bit confusing, but essentially what we have in patients that have been on the gluten-free diet for a while, we have a low sensitivity and a high specificity. So we want the celiac bloods to give us true positives and true negatives. So if it's a positive, we want the patient to have villus atrophy. If it's negative, we want the patient not to have villus atrophy. What unfortunately can happen is we can get a lot of false negatives with bloods in patients who have been on a gluten-free diet for a while. If you want to think about false positives and false negatives in another way, I always like this way of thinking about it. So you've got this gentleman here, middle-aged, being told he's pregnant, looking very happy with the news. And then we've got a lady who's obviously maybe in a second or third trimester being told she's not pregnant, obviously false positive, false negative. And what can happen in these patients who've been on a gluten-free diet for a long time or quite a while, we can get false negatives. So the TTG, the EMA comes back and we feel falsely confident that the patient is following a gluten-free diet and maybe has had villus atrophy healing. And that's certainly not the case. And that's what this study concluded, that a negative antibody test should not be interpreted as an indicator of mucosal recovery or as a proxy for gluten-free diet adherence. If someone's got a positive TTG or EMA, that's maybe more significant. But if it's negative, we can't be guaranteed that that means they're adhering to their diet or having mucosal recovery. So what about symptoms? What about symptoms? So this is a really elegant paper that's just recently come out of the Australian group, Dr. Jason tied in, and it's a really elegant study. What they did was try to establish acute gluten-specific symptoms, and they used a validated outcome measure. And what you can see on the screen here is what they showed was more specific or significantly significant symptoms for these patients. So really it was only nausea, tiredness, and headache seemed to show significant difference. If we actually look at some common symptoms that patients will report about when they talk about maybe being glutened or glutenated, as sometimes referred to in the celiac community, like bloating or flatulence, abdominal cramping, diarrhea, they were less significant. So we can't always guarantee that patient-reported symptoms are genuinely showing that people are being glutened. Yes, if they're having nausea, yes, if maybe they're having vomiting, we can have maybe a higher degree of assurance. But symptoms are not always specific to the idea of someone having gluten in their diet. So we come on to dietetic assessment, and really this is considered the gold standard. And I've put up, maybe comically here, I've put up the RDs are the OGs of adherence. I don't know if none of you know what OG means, but it's slang for original gangster. So parlance that basically means someone who has a depth of experience and knowledge. And certainly I would say dietetically, we have an important role in judging and assessing these patients for gluten ingestion and cross-contamination. So it's very important that we are doing those assessments. And we know that evaluation by a skilled dietitian has been shown to be a highly effective method of assessing gluten-free adherence compared to patient self-report or serological markers. So I don't want to downplay what we can achieve dietetically, but equally, I think we have to be careful about the limitations of dietetic assessment. So this is a study, again, a seminal study out of Jeremy Woodward's group in Cambridge. And I think this is a really important study. So it's optimizing the delivery of care by comparing repeat biopsy. So it looks a little bit confusing. This screen's a little bit busy, but I'll just walk you through it. So this was a group of patients here who had had 3 biopsies. They'd had a baseline diagnostic biopsy, they'd had dietetic advice, and they'd come back after a year or so for a follow-up biopsy, and that had showed persistent villus atrophy. So at that point, they were given further dietetic advice it was identified that we're having sources of gluten in their diet, and they were given advice to try and minimize or avoid that sources of gluten in their diet. So we had about 65 patients, and what we can see here with further dietetic advice was pretty good. 15 patients here more or less resolved their villus atrophy. 14 had normal mucosa after further advice, but 38 had ongoing villus atrophy. And really, it was evidence that really about 55% of patients, maybe as dietitians, we can't find a source of gluten in the diet history, in our assessment. So maybe we can do it pretty well, but there's some evidence of maybe we can't do it perfectly. However, I think we need to be a little bit careful with this interpretation. Because these patients had ongoing VA, they were given the advice, but I think it doesn't necessarily mean they followed that advice. So we have to be aware that these patients, although they may not have recovered, it may not be that they didn't have the appropriate advice, but they may just find it hard to follow it. So I think we have to be careful how we assess this lack of adherence in terms of this villus atrophy result here. But certainly, I think there's some certainly signal here that dietitians are good, but we can't delineate every form of gluten ingestion or cross-contamination. And equally, there's no standardized assessment of how dietitians should assess this. It would be wonderful if there was, and I think in terms of dietetic outcome going forward, this would be something we'd certainly be looking to nationally within the UK. So how can we determine a dietetic approach in patients who may be considered non-responsive? So we know that bloods maybe aren't perfect. We know that symptoms maybe don't indicate a good correlation with gluten ingestion or villus atrophy. We know that dietetic assessment is good, but maybe not perfect. So really, we think that biopsy is the best method we have. It may be not perfect, but if the duodenal biopsy is done in such a way to give us the best opportunity for us to pick up ongoing damage or ongoing lack of mucosal recovery, then we think that is the best, most direct method we have. And these other markers, like bloods and dietetic assessments, are more surrogate markers. So really, you have two situations here. You have no symptoms in a normal duodenal biopsy, no symptoms in an abnormal duodenal biopsy, and then symptoms with either a normal or abnormal duodenal biopsy. And I would say really, with patients who have abnormal biopsy, that is where we may want to consider, are they not following the diet? Do we need to establish a standard gluten-free diet? Or do we need to consider this hypersensitive approach in a subset of our patients? And really, my talk wants to focus on that. Yes, if patients, not all patients, I'm not suggesting all patients need to have a repeat biopsy. Some centers do that, but I'm saying we need to think about what patients may most benefit from it. And certainly, with taking into account the diet, taking into account hematinics, taking into account their bloods and serology, we may be able to delineate who may be most suitable for a repeat dual donor biopsy, and then that could lead on to where we might go dietetically. And yeah, some patients may benefit from an approach like a functional gut approach, like the low FODMAP diet. But again, I think that needs to be done on the basis of they've had mucosal recovery, and we're not just using approaches like the low FODMAP diet in a way that we don't understand where patients are still having ongoing active celiac disease. So in terms of hypersensitivity, there's a couple of studies and issues I want to bear in mind before we just touch on that aspect of it. So gluten tolerance and thresholds has been long debated, and continues to be debated both in the patient celiac community and by trialists and gastroenterologists and dietitians. And I feel sometimes it's a very controversial area. And we can see there's a number of studies here that have looked at it. Some of these are seminal studies in the area. Again, we know that most suggestions are maybe between 10 and 50 milligrams a day. This is just a visual representation of what 10 milligrams of gluten from wheat toast would look like. There's a quote here from a recent review that I think is really good. It's true, as many other biological reactions, cutoffs are relative and reflects the patient's sensitivity to the offending agent. So I think there may be a variety of tolerances to gluten. Now, obviously we need to be careful when we say that. I'm not recommending that people are eating levels of gluten that would cause damage or anything like that. We need to stick to the idea of less than 20 parts per million. We need to have this idea as dietitians and clinicians of this less than 10 milligrams being safe. Obviously, that's a scientific absolute. When we speak to patients, we need to make it more practical. But I think really when we talk about the research, we equally need to be aware of what's going on out there, and there have been some interesting studies. So I just want to highlight two of these studies that I think are important in the area. One from Dr. Jack Savage and one from Dr. Sylvester. So both of these studies maybe suggest that patients on a gluten-free diet, people who are adhering as best they can, still ingest gluten. These studies maybe seem a little bit nihilistic, or it seems like maybe the diet is impossible to follow. I don't think that's what it's telling us. I think, it's acknowledging that for some incidences, it may be hard to follow the gluten-free diet. And I think we just need to acknowledge and see what this means for our practice. So the results of these two trials, if I just look at the first one on your left there, this was a study using gluten immunogenic peptides, which are peptides that you can use from stool or urine to potentially detect gluten in someone's diet. In this study, the stool detected maybe 244 and the urine 363 milligrams a day. And maybe between 3 and 19 of the patients consumed over 600 milligrams of gluten a day. And obviously that's a very high level of gluten in relation to what we know would be a therapeutic gluten-free diet. Again, in the Sylvester study, what's known as the doggy bag study, which I think is a wonderfully named study, they used an ELISA sandwich technique from food samples, as well as using gluten immunogenic peptides. And again, the food samples, 40% of the food samples taken from these patients in this study, it was about 18 patients, no small numbers, but a very significant study, I think. And again, about 20% were over 200 parts per million. And again, the immunogenic peptides were suggesting positive samples in a percentage of those patients. Again, we don't want to be nihilistic and say the gluten-free diet doesn't work. We know from other studies it's therapeutic, and in most people we will induce mucosal recovery, improve people's quality of life. So it's very important we don't feel undermined in our approach, but equally I think with these studies there's a signal there that certainly a subset of patients who appear to be on a gluten-free diet maybe are struggling with it. Now, I do want to talk about, again, this may be seen as a controversial study in the gluten-free community. This is literally hot off the press. It came out last week. This is a study from Luca et al. And this is looking at the safety of gluten ingestion in a subset of celiac patients. It's a real-life study. So they evaluated celiac disease patients reporting voluntary and occasionally gluten transgressions in their diet. So these are patients who were voluntarily eating gluten. And that's the methodology of the study there. So it was over, I think, over a year or so. They had 109 patients who reported voluntarily eating gluten, and these patients completed a food frequency questionnaire, a validated one. They also had capsule endoscopy, and they also had blood tests. So it was a very thorough study, and the controls were 149 patients, which, in quote marks, were adhering to a strict gluten-free diet as determined by a dietitian and food frequency questionnaire. So what were the results of this study? So the first aspect is that the non-compliant group was maybe consuming, on average, a mean gluten intake of 185 grams of gluten per year. The frequency of gluten ingestion was usually once a week or once a month. You can see maybe about 75% of the patients were either having gluten once per week or once a month. So it's a significant intake there. And a subset of patients were obviously eating gluten daily. There was no statistical difference in Marsh scores between compliant and non-compliant groups. So I just want to put this up because it's important we understand what's going on here. So what you have here is a range of Marsh levels from biopsy. And you can see there's a disparity in terms of numbers here. Obviously, in the compliant group, there was about 149. And in the group of patients who were non-compliant, it was about 35. So there is a disparity in terms of numbers, and those numbers are up here. But certainly in terms of percentages, what you can see, I think what's really interesting here is the Marsh 0 and the Marsh 1. There's a percentage of patients here who are regularly consuming gluten and had mucosal recovery. Now, again, I don't think this is a paper that changes practice, but this is a paper that I think needs to be replicated, and it's a paper we need to be aware of and understand what this may mean for implications for maybe our practice in the future. Again, I think it's an interesting and important study. And also the non-compliant group, only 23% had positive TTG values. Again, it highlights that positive bloods may not be as accurate as we think they are in terms of telling us what people are doing with their diet. So the conclusions from this study that a group of celiac patients with long-term gluten intake showed no significant clinical symptoms or histological abnormalities. The important bit here is a better understanding of the mechanisms by which some patients may reach a degree of tolerance could result in a personalised GFD. But I want to emphasise something here. You know, these groups here, we don't know. These are suggested as people who are following a diet. This was through a food frequency questionnaire. Food frequency questionnaire have their difficulties, and we just need to be aware that just because a food frequency questionnaire would indicate someone was following the diet, maybe they're compliant, it may not tell us the whole story. So I think we have to have a note or a tone of caution about our interpretation of the study, but equally I think it may signal something here that needs further research. So I do want to get onto super sensitive, but I want us to bear in mind that when we get onto super sensitive, there are some patients who struggle when they're adhering to avoid dietary transgressions. And there are also some patients that maybe have a tolerance to gluten that we need to investigate further. But when we talk about hypersensitive patient, there's two approaches we need to think about. So there's one that's been labeled a super sensitive gluten-free diet. And really historically, there's three aspects to this. There's a standard gluten-free diet that we would recommend for all patients with celiac disease. But these patients who we assess as being non-responsive, ideally on biopsy, really should be on biopsy. These patients have ongoing villus atrophy, ongoing mucosal damage. Then we may consider removing codex wheat starch, removing gluten-free oats, and removing all forms of barley malt extract from the diet. And that is a super sensitive approach. It sounds easy. It's easy to describe. It's actually it's harder to implement. So it is another level of restriction on someone. And though it's easy to describe, I would say in practice for patients, it's hard to do. They've got to be very self-motivated to do this. It's a lot more vigilance of their food environment, a lot more reading of labels, and potentially it's taking things out of the diet. A lot of label gluten-free foods these days use gluten-free porridge oats in their products, so it's important to bear that in mind. Now, when we look at the dietary approaches and particularly this aspect of supersensitivity, I'm going back to this study by Dr. Jeremy Woodward again. They looked at 95 patients with persistent villus atrophy, But what they also did was take 29 patients with the dietitians were unable to identify any source of gluten cross-contamination in the diet, and they were given this super sensitive approach. And again, what you see is this improvement in about 18 patients out of this 29 who were designated super sensitive, but 11 had ongoing VA. So it's definitely, again, a signal there of this diet can improve people's recovery. However, I think there's an important caveat. This study was done in 2013, and the caveat is here. The majority of the cases in this study were subject initially to less stringent standards of up to 200 parts per million. So this was before the recommendation, the legislation about less than 20 parts per million came in. So I think we have to have that caveat when we interpret this study. It's important. It gives us a signal that, you know, this may be an approach we can use, but equally it may need replicating, just given the fact that we know labeled gluten-free foods are at that cutoff point, mostly around the world, at less than 20 parts per million. So I also want to go on to the other approach, which is the gluten contamination elimination diet, or the GCED. I've put in here of what you would imagine is the Eat Well plate, which is what we use in the UK when we're talking about healthy eating. Imagine if this is a gluten-free one and these are all gluten-free products. So what happens on this approach is it's highly restrictive. These are patients that are not allowed to have any form of processed foods, no labeled gluten-free foods, no dairy for the first 2 to 4 weeks, no tinned foods initially for the first 2 to 4 weeks. It leaves out, you know, potatoes, rice. Rice should be ideally labeled gluten-free, and fresh fruit and veg, fresh meat and fish, etc. So it is very, very restrictive. And the study, again, that came out from this was quite interesting. So it was a case note review of about almost 1,300 patients. And over that sort of 7-year period, about 2.3% of that cohort was suggested to go onto the GCED. They had 17 compliant patients, and 14 of those patients had mucosal recovery, and 11, and this is the important aspect, were able to return to a traditional gluten-free diet. So this is really interesting. It's a fascinating study. Unfortunately, the one other study that's been done in this area didn't quite replicate these results. And although it's a fascinating study, the issue that I've had clinically is patients do not always want to follow this approach. And I would encourage anyone who's considering this with a patient that they absolutely need to have biopsies. They need a diagnostic biopsy, a repeat biopsy if they have ongoing symptoms. And also the patient needs to agree to the fact that if they do this for 3 months, for 12 to 16 weeks, that they will likely need another repeat biopsy at the end of the process to see if it's been successful. And some of these patients have even had another additional biopsy beyond that. So it's quite an interventional approach with the outcomes being defined by biopsy. If someone is going to go in it, I really recommend this paper, which is a really practical paper about how to implement it. But again, patients need to realize this. If this is being suggested, it will necessitate multiple duodenal biopsies to do it properly in most patients. So I think about this approach in concentric circles. I think if you're like, you have the celiac population who we've managed to diagnose. And then we have a subset of that population that is really unknown at the moment. This isn't proportionally representative, it's just an unknown who may benefit from a supersensitive approach. And then we have a subset of those patients who actually want and can implement that approach. I don't think we can always fit this approach into a protocol, because we can say patients may benefit from it, but they may not be able to achieve it or want it. And I think that's very important to bear that in mind. I've known patients who've done this, they've implemented maybe a supersensitive or a GCED, the gluten contamination, off their own bat, just because they felt symptomatic. And obviously that can lead to malnutrition, can lead to vitamin and mineral deficiencies. So I think we have to be very careful about how we implement these approaches, given that the data suggests that a lot of people with celiac disease will have cross-contamination even when we think they're adhering. So I just want to wrap this up a little bit with thinking about the rise in diagnosis and how this fits in with supersensitivity. So this is a paper that's very recently been published, looking at the ever-expanding exponential rise in different countries of celiac disease. And the conclusion here, there's a consistent pattern of increase in incidence over time around the world. And anyone who works in the area will be very, very familiar with this pattern. And within this, we know, and it may seem like I'm speaking very from a dietetic perspective here, but we know that all the guidelines say that dietitians and dietetic support is central, still central to the care of patients with celiac disease. However, I feel this is more of an aspiration than what's actually happening in fact. And it does tie into maybe how we treat patients who are non-responsive, may have hypersensitivity. We know historically from this very important study back in 2017 from my colleagues in Coeliac UK that maybe only a third of patients were having appropriate advice that we would consider as a standard from the British Society of Gastroenterology. This important paper coming out of Australia, again, we were saying a third of patients not having any dietetic input, 40% of patients were non-adherent, and 40% more worrying, we were restricting other food components. And then this is soon to be published from our centre, that 40% of dietetic departments only able to offer 13 to 30-minute consultations, and 50% had no specific pathway for celiac patients, never mind a dedicated pathway for people who are non-responsive. And I want to end with a little bit of, if you like, these are some back of an envelope calculations, but I just think we need to think about what this may mean. So we know that maybe 75% of people with celiac disease remain undiagnosed. And we know that maybe 30% of patients are still symptomatic. And a lot of those patients aren't having any follow-up at all. And for the undiagnosed ones, how many of them symptomatic? How many of them need specialist, ongoing, personalised diets? And if we were to do this properly, we need to think about how we diagnose these patients, how we recognise patients with celiac disease, but how we follow up people who are not responding to dietetic care or the gluten-free diet. And going forward, I think we do need to think laterally. We need to think in terms of other ways that we can support patients going forward, and how we can have protocols in place to identify these patients so we're giving the right patient at the right treatments at the right time. So I'd just like to end by thanking all my colleagues, Professor David Sanders, Dr. Imran Aziz, Dr. Atpam Ray, and my dietetic colleagues, Christian Shaw and Rachel Buckle. I'd like to thank all the celiac community out there in Coeliac UK again. I know it's a difficult time at the moment. I hope everyone's well and staying safe. And I'd like to end on one positive moment. I know we may not be socializing in the same way we are at the moment, but in a couple of years' time, we're going to have the International Coeliac Symposium in Sheffield, and I look forward to welcoming you all into my wonderful city. I hope you all stay well. Thank you so much for listening. Thank you. Bye.